Hi, I'm Ruth O'Regan. I'm the Chair of Medicine at University of Rochester. There are two ways to assess whether a cancer is HER2 positive. One is by using immunohistochemistry, which detects HER2 protein on the cancer cell. And the other way is by doing fluorescence in situ hybridization, which looks at the HER2 copy number, the HER2 gene copy number within a breast cancer cell. Really, the gold standard for testing for HER2 is immunohistochemistry, or IHC. And that relates back to the initial identification of the HER2 protein being overexpressed on about 25% of breast cancer cells. So a lot of institutions will do an IHC test first. If it's 3+, many institutions will not go on to do FISH. However, if it's equivocal, so in other words, if it's 2+, the guidelines currently would suggest that you should do FISH. Now, what's happened over the last 10 years or so is that a lot of places have actually stopped measuring the protein using IHC and go straight to the FISH testing. The reason for that is that the FISH testing is perhaps a little bit less subjective, and we know it correlates quite well with the HER2 protein expression. But I think it's important that we remember that the target of drugs like trastuzumab and pertuzumab is the HER2 protein. So it is important that we do keep that in mind. Now, HER2 testing has become quite complicated over the last several years because traditionally what the FISH test did was it measured the ratio of HER2 to chromosome 17 because the HER2 gene resides on chromosome 17. So a normal cell should have equal ratios of both of these genes. So the classical definition of HER2 positivity by FISH is where the ratio is greater than 2.0 or 2.1. We've never been able to show that the magnitude of benefit from HER2-directed therapies, however, correlates with the level of or the level of the ratio. I think the idea of just doing immunohistochemistry is completely reasonable. If it is 3+, you don't necessarily have to do FISH, although a lot of institutions do for confirmatory reasons. However, it's also reasonable to do FISH, and you can always do immunohistochemistry if the FISH is equivocal, because that happens in a number of cases, particularly because now we take into account the number of HER2 copies, not just the ratio. So you end up with, I think, somewhat more equivocal cancers for HER2 positivity than perhaps we had before. And that's really where the IHC can be very valuable as well. So just to kind of summarize, if you do IHC and it's 3+, you can do FISH. You don't necessarily have to do FISH. And based on the older studies that have been done, the HER2-directed therapy should work in those cases. If the cancer is IHC 2+ or 1+ in certain cases, then it would be recommended to do FISH. If you start with FISH, if it's clearly amplified based on either the ratio of the HER2 gene to chromosome 17 or indeed the copy number, it's probably not necessary to do the IHC. However, if it's equivocal, which it can be in a lot of cases, then doing the IHC makes perfect sense. So there are some nuances here, and I think one of the problems with the newer guidelines for HER2 testing is that that wasn't the criteria that were used in the initial trials that looked at trastuzumab.